All right, so in week 4, we are covering 2 chapters, chapters 9 and 10. Chapter 9 is here on the screen, and this one is on pre-analytical considerations. So we are going to go through this one first. All right, so a pre-analytical phase is just any part of the process before the testing begins. So phlebotomy would very much be in the pre-analytical phase. So the collection of the sample, identifying the patient, all those kind of things are all considered part of being pre-analytical. So part of pre-analytical, and a term that often resides in this part, is the term basal state. So this is somebody that's at a resting metabolic state. It's often in the morning after they first get up from sleeping for at least, a good 12 hours of just rest and relaxation. Doesn't that sound amazing? 12 hours. Wow. But, there's not a lot of effect on the body yet as far as diet and exercise and other things. When you start moving around, then you're not at a basal state anymore. So anybody that would be an outpatient where they're walking into the clinic is not at a basal state. Basal state would be better defined as like those patients that are in the hospital and you go draw them at bedside upon waking in the morning after a long period of being at rest in that bed. So other variables that come into play that affect the pre-analytical phase and have a role, all of these are variables that affect certain tests, from age to altitude, dehydration, diet, and so on down. You do not need to know or memorize this list. It's just FYI. You'll eventually learn about all those different tests on the side there, but it's just kind of informational on what can get affected and how the tests, and then what tests might get affected as a result. All right, for as far as picking sites, different site selection for drawing on veins, you guys have kind of started to get a feel for this already, but anybody that has burns or scars, obviously we don't want to draw at that site. They're going to feel, it's not going to, you can tell when somebody's been burned, or you can feel when it's been scarred, and it's not the nice, vein-like feel that we're used to feeling right now. Tattoos, ideally, we do not want to draw through a tattoo, but we do find a lot of people have full sleeves of tattoos, so you just kind of have to do what you have to do. But ideally, we'd like to select a site that's not in the tattoos because, they've had needles go in there, could have had some scarring along with that, that kind of thing. But if you have to, you have to, because there is a lot of people with lots of tattoos now, but just kind of an FYI on that. Any vein that's damaged, we're going to try to stay away from. Any vein that has an active bruise on it, we're not going to draw from it. If they have edema, which is accumulation of fluid where they're kind of puffy, we're not going to draw on that either. Mastectomy, if they have a mastectomy on one side, we need to not draw that side. We would go to the other side. If they're obese, that causes complications in that the veins are going to be deeper, not easily seen, kind of hidden from view, that kind of thing. So they're going to be harder to find. Some devices that might be in place, there are sometimes an arterial line put into place within an artery. We are not going to draw from any of these, just so you know. These are all things that either we would get nurses help to access or we would just leave alone. Arterial line is obviously going to be arterial blood. So in the case of us, if we want a venipuncture sample, we're not going to play with that. If they have a fistula or that arteriovenous shunt where they basically have fused the artery and vein together in the wrist, a lot of times people get this with dialysis, we're not going to draw on that side of the body. We would try to stay away. And you can always tell if they have a fistula because it'll be like a buzz or a whir feel under the skin in that. And they will tell you if they are on dialysis and they have that. So draw the other side. Heparin or saline locks, a lot of times this gets done by nurses if they put like a IV start in but don't connect the IV. It's just sitting there ready in case they need it future. We could probably draw from that if we get the nurse to come in, give it approval, and they collect it. So nurses are the ones that would have to put the syringe on, flush it, and then collect the blood. We can't just use it for our liking, but it is there. Maybe they'd allow us to use it if we asked and they came in and did it. Otherwise, you're going to always draw below that site or on the other side. And IV sites. Anywhere there's an IV, the rule of thumb is always draw below the IV. Because what the deal is when somebody has an IV and they're pumping fluids through that IV into the patient, As they're doing so, they are pumping those fluids. We want to draw below anything that's going to be away from where the fluids are going to be, because those fluids can contaminate our sample. So below the IV site or on the opposite side. So if they have an IV on their right elbow area, we're going to draw on the left side. If we cannot find a vein on the left side, then maybe we can draw on the right hand. But otherwise, you always below, otherwise try to get to the other side. If you absolutely had to draw on the area of the IV, there is ways that you can do it. You would have to get, again, nursing approval to shut the IV off for at least 10 minutes, let it kind of clear out of this area, and then go ahead and draw. But again, it all has to be approved and done by the nurse, not by us, because that patient is in their care. All right, so there's just an example of what a fistula looks like with that fusion of the vein and artery down in the wrist. And again, it'll have that buzzing or whirring feel to it. There's also going to be other catheters, like a central venous catheter that's put into the large vein and superior vena cava, a port. This is often done for leukemia patients who are constantly being drawn and undergoing procedures. So again, nursing staff can hook up a syringe, flush it, and then collect the blood from that port so that we don't have to keep sticking those poor patients over and over again. There's also a PICC line, and that is inserted into the peripheral venous system up into the heart area then. So here's the central one that goes into the superior vena cava. And then here's the PICC line, which is started in the peripheral system down in the arm, but it does go into the hearts. Again, all are specialized lines to collect from. We cannot collect from those on our own. We would involve nursing staff to help do it because they have been trained on how to flush it properly and then collect. All right, complications for the patient, of course, allergies. I'm hopeful that most places have gone latex free. Once in a while, you'll still see them around, so always take that into consideration. There's a lot of people that are allergic to different antiseptics. So if they're allergic to iodine or something like that, adhesive, lots of people allergic to different types of adhesive, so you gotta, take that into account. Hopefully they'll let you know. Watch for excessive bleeding. That's why I'm always telling you guys, look to see if the patient's done bleeding. Don't just wrap it right away. Don't be so quick, because, we're in classroom, pretty good, healthy people, but in the real world, a lot of people are on different medications, and a lot of those medications lead to thin blood, which means that they tend to bleed for longer periods of time. So with that excessive bleeding, make sure that you really have them hold down if they can. If they can't, you got to hold down the gauze. And then hold it for quite a while. Do not wrap them until you're absolutely sure that that bleeding spot has stopped, because otherwise they're going to return to you with huge bruises up and down their arm if you didn't let them. And I've seen it happen. So it's a very real situation. Of course, we're all aware that people get nervous with needles. There's a lot of people that get so nervous that they might faint, what we call syncope. That is a real situation. You just have to watch. The minute someone sits in your chair, if they're nervous, they're very much, anxious. You can see it on their face that they're very unsure, kind of panicky feeling. You know what it looks like when somebody's uncomfortable, kind of twitchy. They're kind of a little paler. And then when they start to go to faint, their face becomes this really unnatural white gray color. It's like all the color just drains out of their head. Like you can't believe that the color they turn is possible. But the minute you see that color in their face, it's a clear sign what's going to happen next. So, you just do the best you can. You try to not let them, if they're sitting up, try to watch their head, but at the same time end the process of drawing blood as safely as you can. Never leave the patient's side. Ask for someone to get help or a nurse. Don't scream or run or cause a chaos. Just try to maintain your calm and get help. And then the nursing staff has to come over, take their blood pressure, measure their heart rate, and then kind of clear them at the end. Nausea, vomiting, of course, if people are sick or if they're nervous, whatever it might be, that is a very real possibility. When we used to do strep collections, I actually had to do strep collections in my first job. We would collect all the streps, influenzas, and draw blood, along with being a lab tech. And the streps were horrible, especially if people had really bad gag reflexes. It was a very real possibility they could vomit on you while you were trying to collect that strep from their throat. So not ideal. You just kind of have to learn to stand to the side as much as you can. So petechiae are those little raised, well, they're not raised, I should say, but little red spots on the skin. They end up indicating little hemorrhaging of capillaries. So if a tourniquet's been applied for too long or something like that, that could happen. And then seizures, convulsion at the end. So all these are different things that could occur. The goal for you is to stay as calm as possible, not panic. The minute you panic, you lose all thought of what you should be doing. Just try to maintain calm, finish your process, the technique you've learned as quickly and as safely as possible, and get someone to help you, but without alerting or alarming anybody else that's a patient in the area. So that's what petechiae look like. The purpura are a little bit larger spots, so both indicate little hemorrhages on the skin. You know, if you see this, try to stay away from it as best as you can for drawing blood. All right, so with drawing blood, there are some procedural risks. Hematoma formation, which is basically where you get the bruising happening. It does happen on hard draws, especially. Iatrogenic anemia, that is a term that I do very much want you to know. Iatrogenic anemia means that if somebody is getting so much blood collected through phlebotomies that eventually leads to giving them an anemia. So they might have started out with a good hemoglobin level, not anemic, and then because they had so much blood removed for testing over like a short period of time, they ended up becoming anemic. That is what we would call an iatrogenic anemia. So do be familiar with that term. Other risks are, of course, always an inadvertent arterial puncture. So the goal is always, when you're feeling for the vein, make sure there's no pulse that you feel, because a pulse would indicate an artery. That's why we're always feeling with our fingers, not the thumb, because the thumb has a pulse point in it. And then we're trying to never draw that vein that's on the interior of the arm, because that one is near an artery. So that's always our last choice if possible. So always trying to stay away from an artery. You'll know you hit an artery because the blood will be bright red and it will pulse into the tube. So again, when you feel, just make sure you feel no heartbeat. You should be good. Infection, that's why we do a really good cleansing process with the alcohol pad. Never retouch it without your finger being cleansed again, so that you ensure that there's no infection risk. Nerve injury, this can happen if you hit a nerve. It will cause numbness down their arm, you know, some tingling. So the nerves will eventually repair themselves, but it's not comfortable for the patient. It's not ideal. So the goal with this, again, is the better you are at your technique, and the more confident you get in knowing and understanding how to feel for veins, where to select your vein site, the less risk there is for nerve injury then. Reflux of anticoagulant, what that means is when you put a tube on, and if you have the tube angled up in the air, there is a risk that that anticoagulant, the tube, could go back up into the needle and then into the vein, and then when you put the next tube on, go back into that and contaminate. So ideally, you want the tubes to kind of be in a downward motion, like the bottom to be kind of facing down, so it helps fill the tube without any risk of it going back up in. So that's just kind of that. All right, as far as samples, the best technique will get you the best quality sample. So if you have a poor quality sample, you're going to get poor results for your tests. Always be aware of your tourniquet for hemoconcentration. Tourniquet is always a minute or less, and that will help reduce hemoconcentration from happening. So hemoconcentration is a word that I do ask you know, and it means that you will have fluid passing from the vein basically over into the tissues. So all of a sudden you're losing fluid out of the blood and it's going into the tissues. Well, when you go to measure their tests, some of that fluid contained things that you were measuring, and all of a sudden you're going to get false results because it's either not there as much as it should be, or it's too concentrated because too much fluid left. So it can affect the test results. So that's why we always say a minute or less to the tourniquet application to help reduce that hemoconcentration. Hemolysis, this can occur with a bad draw if it wasn't in a good place on the vein, if it didn't fill properly and it was like on the vein wall or something. If it was just a hard draw with small veins in general, sometimes it can happen. So it basically means that the red cells have lysed. Any sort of pink or red color to your serum or plasma will indicate you have hemolysis. So the biggest test that gets impacted the most with hemolysis is always potassium. Potassium becomes hugely increased whenever there's any slight bit of hemolysis present. Otherwise, there are others that are listed as well, but just kind of a mention on that. Partially filled tubes, we've already talked about that for the importance of light blue tops at critical 9-to-1 ratio. But again, keeping sure that all tubes are filled as much as possible. So we know that the light blue top is very critical, but it's also critical on EDTA, sodium heparin, lithium heparin, those ones, anything that has an anticoagulant. Ideally, you want to try to hit the amount, the volume that's labeled on the label. You don't want to underfill them. There is, some awareness there, but we've always discussed the light blue as the most essential one, but the others are important too. You don't want to underfill them or they're not going to be any good either. All right, so, and this is just a cute little cartoon. Don't worry, I'll find a good site soon. I swear I've heard these horror stories from 20 zillion patients. Last time I got poked 9 times, sometimes maybe it's true. It can happen. You hear it. Some of it has to be true, but the rule of thumb is you get twice. You can't get it in 2 times, you're out. You're done. And after that, it gets to be a mental game. And I think you guys have experienced the mental game a little bit in class now where your own brain kind of gets in the way of how you can do sometimes. So that's just kind of a reference to that. All right, now let's switch over to our other PowerPoint, which is chapter 10. So chapter 10 is actually capillary puncture. We are going to start adding this in to our labs. So another technique that we get to do every week now. I know you guys never thought you could be poked so many times. All right, so with capillary puncture, the equipment slightly different. We're going to use a lancet. Now lancets can vary depending on if you're using a heel lancet or finger. Of course, we're using finger. We're not puncturing each other's heels. That's 1, gross. 2, most people have a lot of calluses at our age on our heels, so it's hard to get through. So we're using a finger, but there are special lancet for heel punctures for little children. So collections, we're going to use tubes that look really similar to our tubes that we use in blood draw, but they're just small. They have the same color tops there, you can see, so they'll have the same anticoagulant, but they're just really a lot tinier. So because we can only get so much blood out of a capillary collection. The one over here on the left, I guess it would be, these are microhematocrit tubes. Sometimes we can draw into there and spin down in a microhematocrit centrifuge, but that's a really, really old school technique, not done really in the mainstream lab anymore, so we're not going to worry too much about that. We pretty much draw into these tubes that are on the right. All right, there is a whole process for also doing a capillary blood gas collection. I am not going to test you on this. I'm not going to worry about this, so you can ignore the capillary blood gas references. So warming devices, I will mention that. A lot of times, especially when you go draw newborns, which are heel punctures, it's always a good idea to warm it up. It'll help the blood flow increase to that area and help you get an easier collection is the hope. All right, so this is just talking about the composition of capillary puncture, or capillary blood, I should say. It is comprised of a variety of items: arterial, venous, interstitial fluid, intercellular. Out of all of that, it most closely resembles arterial blood. So because of that, some of the values on what we test for might be a little bit different than what we would see in venipuncture, but just keep in mind it does closely resemble arterial blood. So reasons why we would perform a capillary, mostly it's children and infants. Anybody, I should say, younger than a year is going to be a heel puncture. If it's older than a year, then we would do more capillary, unless maybe they're really, really small and petite. But again, we do capillaries on children and infants, one, because they don't have a lot of blood volume in them. We want to prevent getting too much blood from them and anemia happening. And then it would be cardiac arrest happening because you took too much out. So, that's the idea, is we'll take lesser amounts from them because they have a lesser amount of supply in them. Other thing is, venipuncture can be really tricky on children. They're nervous, they're freaked out, they're panicked, they're scared as crap. They have all these people around them they don't know and they don't like in their bubble. And so as a result, they cry, they kick, they move, they're not going to hold still for you. Once in a while, you get a really good one that just lays there and you're like, wow. But they are moving. They are going to be really squirmy and really hard to, pin down. You actually have to get a team to help hold that child down in place for you to draw their arm. I mean, you have to do what you have to do if you have to collect their venipuncture, I've done it because the amount of blood I needed was more than the capillary size, and it was just easier to get the venous. But it's not ideal. The parents can be freaking out too, so it's kind of a mess. So that's kind of the indication for children. If it's for adults, normally we're always doing a venipuncture. Sometimes we will do capillary, especially for point-of-care tests. So point-of-care tests are those analyzers that are kind of handheld at the bedside. Think about people's glucometers when they check for glucose monitoring for their diabetes. They'll quick prick their finger and check their glucose results. That's a point-of-care test. Or we might get them coming in just to quick do a hemoglobin check on a point-of-care analyzer. They just need to track their hemoglobin level. We could quick prick their finger for that. So if they're little point-of-care analyzers, yeah, capillaries are great. They're quick and easy. That's the point. Otherwise, we really don't use them because we need more blood than that. It's too tedious of a process, too little of a sample to play with for adults. All right, tests that absolutely cannot be performed by capillary. So there are some things that if these get ordered, you have to draw the blood no matter who the patient is. So erythrocyte sedimentation rate, what we call SED rate, ESR, that requires a ton of volume of blood. That actually measures for inflammation. It's not the greatest of tests, but that is one that's drawn on an EDTA lavender top. It needs almost the full EDTA blood tube full of blood in order to run it. So you can see it needs a lot. Capillary wouldn't do it justice. Coagulation studies, so again, anything that's going to the coagulation department with the light blue top tube, need to draw it on a venipuncture because we need to make sure that anticoagulant ratio is held steady, all that kind of thing. Plus, we're looking for clotting factors. If you do a capillary puncture, what's the first thing your body's going to do when you puncture their capillary? They're going to try to seal it up. They're going to try to clot. So, you could get some false positives there on the coagulation side. So venipuncture is much better. Blood cultures. Blood cultures also require a ton of volume. For children, it's 1 to 3 mils. Well, you're not going to get that out of a capillary. 1 to 3 mils doesn't sound like a lot, but just wait till you guys start doing capillaries. You're going to be dying just to try to get 500 microliters. So it's not ideal. And then for adults, it's 5 to 10 mils in each bottle. There's 2, so it's going to be 10 to 20 mils. So it's a lot of blood for blood cultures. So those are 3 main tests that usually never performed by capillary puncture. All right, order of draw. There is an order of draw to doing the capillary process, and it's kind of backwards from what we've learned on the venous parts. So the very first thing is if you need to make a peripheral blood smear, do it right away before the clotting starts. And then we always get our purple top, or lavender top, I guess you call it, EDTA tube first. Because we're not trying to get the platelets to clot, which platelets want to clot right away, and part of the hematology measurement is on the platelet count, we want to get that out of the way before that starts to happen with getting the EDTA tube. Then you can collect whatever other additive tube you have, whether it's like a green top, and then last would be your serum top. Because if it clots in the serum, not a big deal. We need it to clot eventually anyway. So it's a backwards order of draw for a capillary. All right, so for the actual steps, of course, you always get your test request, identify your patient, put your gloves on, and then for your hand draw, you're going to have them put the palm up, hand extended to you, and you kind of put it, position it however is most comfortable for you. So that's kind of the idea there. You're going to select your site. Now, you want to use either the middle finger or the ring finger are usually the best fingers. You don't want anything that's going to have scars, cuts, bruises, rashes. If it looks like really cold or slightly blue color, none of that's ideal. So again, anybody over a year old, you are going to be using the middle or ring finger. Typically, we try to use their hand that they do not write with. It makes it a little more comfortable, but I don't really care. I just like the middle or ring finger on whatever side I want, typically. Again, if they have had a mastectomy, though, you cannot play with that side, so do keep that in mind. All right, so there is this whole deal with the whorls of your fingerprint. Who knew that your little fingerprint lines would come into play here? But the way that you cut on a lancet, or say do an incision, is you are doing it perpendicular across the whorls where it says this, and it shows you that angle. You see how that's perpendicular? It's going all the way across those whorls. That is the right way to do it. not parallel alongside them. So you kind of want to do it between the, not in the direct middle of your finger and not at the very outer edge, right in the kind of between those areas on an angle across those whorls, and that's the ideal side. So we will get good practice at that in class. For as far as heel goes, you want to use the medial or lateral plantar surfaces of the heel. So that shows you in the picture. Do know that that's important to remember on heel punctures, using medial or lateral plantar surfaces. You never ever use the very back side of the heel because you will risk puncturing the calcaneus heel bone. So keep that in mind. You cannot use that back side because of the heel bone risk of puncture. The other big thing with heels is you can never use a lancet that goes deeper than 2 millimeters. That's why they make special heel lancets to protect that. So again, you can never puncture deeper than 2 millimeters. So all that's really important advice to keep in mind. All right, warm the site if their hands feel really cold. You're going to always have somebody in class that has really cold hands. Run them underwater if they can, but otherwise we always have like hand warmers in the actual real world lab that they can put on there for a while. So cleanse, you're going to use, alcohol pads just like normal unless they're allergic, but you just kind of cleanse and get your equipment ready. So you're going to have your lancet, your tube that you need or tubes, Band-Aid, gauze, that's kind of your stuff, and your gloves, of course. So once the alcohol has dried, nice and air dried, at least 30 seconds, then you can go ahead, puncture the site with your lancet and discard the lancet. I mean, the lancet needle thing will suck right back up into it. It's kind of a self-safety. So you can set it down on the table, but you are going to need to dispose of it in the sharps eventually. But it has a self-safety kind of technique on there. Very important that you always wipe away the first drop of blood, because that first drop of blood will have contamination from like tissue fluids and stuff. We don't want that. So wipe that first drop of blood away with gauze, and then you can go ahead and fill your EDTA or other tubes or whatever you might have. You're going to kind of do this squeeze to build up a drop, and then trying to get a nice big hanging drop to just drip down into the tube. You're not trying to milk it like a cow udder, where you're constantly squeezing and squeezing and squeezing. Sometimes you kind of have to a little bit. I mean, some people are going to be like no blood coming out, others are going to gush it. It just depends. So try to squeeze to get nice big drops and then let that drop in and then squeeze again to get a nice big drop. That's kind of the idea. Other things are, do not scrape your skin with the tube trying to get that blood drop. It's easy to want to just scrape it along to pick up that drop. You don't want to touch the skin and get all those skin cells in there. So this is where capillaries get to be a pain in the rear. I personally would rather draw somebody any day of the week than do a capillary. I find that they're tedious, that they are, they take a while. Like, I guess that's tedious, isn't it? They're messy sometimes. And just, they can be hard to get. And it's a lot of work. So some people are excellent at it. I myself never developed a great technique. I mean, I can do it, but I don't love it. I always went to drawing instead. But once you get enough blood, there's lines on the tubes where you can fill to minimum, and the minimum line is on there. Then you can go ahead and put gauze and apply pressure at the site. Label the specimen just like always, and then check their site and apply bandage. So here we're usually just doing a Band-Aid unless they're allergic or something like that, and then you just kind of clean up. So the other big thing is when we start doing this in lab, I'm going to start to go around and check for clots. There's a whole technique to collecting this blood in the tube and making sure it mixes with the anticoagulant in there and not clot. If you get a clot in there, that whole tube is going to be garbage. And then it's like, all that work for nothing. So we will go over this in class and lab together and practice, which will make it more understandable. All right, like I said before, do not worry about capillary blood gases. It's informational. We're going to skip through this. You can just ignore it for now. Bilirubin collection. It's very common to get bilirubin orders on brand new infants because they might come out slightly jaundiced or yellow skin coloring. So they get put under a Billy light, so you might need to monitor their bilirubin levels. Again, remember with bilirubin, we have to protect that sample from light. Light will break down the bilirubin. So when you draw that sample, typically those bilirubin tubes, those chemistry tubes are already very dark in color to naturally protect that bilirubin level within it. So just kind of FYI on that. Yeah, so that's kind of it. So a fun new technique that we're going to add in every day of lab to what we're doing. So we will start this soon, and I look forward to seeing you guys, and I hope you guys have a good week up until Wednesday. So we'll see you all on Wednesday. Thank you.